Welcome, everyone. Thank you so much for joining us today. My name is Dr. Louise Ivers. I'm the faculty director here at the Harvard Global Health Institute. It's my pleasure to welcome everyone to HTHI's Global Health Research and Innovation Speaker Series. This is our monthly series hosted by us and designed to showcase the latest advancements in global health research, with the goal of fostering dialogue and elevating innovative solutions that advance health outcomes worldwide. We welcome you today and to continue to join us for more timely discussions and critical insights that arise from the field every month. I have a couple of notes today. The session is being recorded through Zoom, and the recording of the session will be made available on the HTHI website and YouTube page in the coming days. We will have time at the end of the presentation to answer your questions. If you have a question for Professor Yip, you may submit it through the Q&A feature on the bottom of your screen, and we will do our best to get to those questions at the end of the presentation. So with that, please allow me to introduce our speaker today. I'm really delighted to host Professor Winnie Yip. She's a professor of global health policy and economics at the Harvard T.H. Chan School of Public Health, and the faculty director of the school-wide Harvard-China Health Partnership. Professor Yip is a member of the National Committee on U.S.-China Relations, Track 2 Health Dialogues. She served as the past president of the International Health Economics Association and has consulted for numerous international agencies, including the World Bank and the World Health Organization. She holds a PhD in economics from the Massachusetts Institute of Technology. Her research focuses on rigorous and policy-relevant health system evaluations and the design and testing of innovative health system interventions to improve equitable access to efficient and good quality healthcare. She applies this approach to developing viable and effective models of population health-based integrated delivery systems in China and India. She is also very interested in the implication of China's aging population for the country's health system and in designing and piloting innovative elder care systems to support older adults in living meaningful lives. Professor Yip has studied and advised healthcare reforms in the wider Asia region, including Hong Kong, Taiwan, Thailand, Malaysia, and Vietnam. We're thrilled to have her with us today, and with that, it's my honor to welcome you, Professor Yip, and hand the floor to you. Thanks.
Great. Thank you very much, Louise, and thank you for the Institute to invite me to speak at this seminar series to be able to share with you the work that I have been doing in and on China for the past many, many years. First of all, let me share my slide first. I want to say that even though today my topic is China's experience, I need to start by saying that China is very big, and there are obviously a lot of variation and heterogeneity. And of course, I'm not going to be able to speak about every single bit of detail. So I'm taking a very high level perspective for this talk. And also, I'm going to take a more of a systemic perspective for the talk rather than telling you one slice of the whole of specific projects. So I'm going to start by talking about the reform that China launched in year 2009. Why is it an important reform, and why do I pick on it to focus on as a starting point? There are several reasons. Number one, 2009 signified the beginning of a change in priority and direction for China in terms of the guiding principles they use to finance and organize its healthcare system. And it also is the beginning point of a continuous process of reform that is still continuing today. So to understand today's what is happening in China, you need to understand 2009's reform. And what is the major departure in the 2009 reform compared to previous years' healthcare system in China? Before 2009, China's healthcare system is very much organized around the principle that the market works. Therefore, you can use market as the main mechanism to organize its healthcare. And 2009's reform is the first time the government declared that healthcare has a lot of social welfare characteristics, and therefore the government has to play a significant role in its healthcare system, in particular in financing it. And 2009 is also important because it was around that time the Chinese government as a whole is shifting from the sole focus of economic development to a new development strategy that emphasized the balance between social and economic development. Because before, under the sole priority of economic development, the idea is that everybody should be made to get rich, and if they have enough money, they can just purchase their health care. That was sort of the principle in the policymakers' mind. And from 2009 onward, the priority for healthcare is for equity, and health is elevated to an importance in the policy agenda as a social development that is important for the country's whole development. And that's why 2009 is important. And of course, there's a catalyst. And the catalyst is that the SARS outbreak in 2003 made the Chinese leader realize how broken his healthcare system is. And at the same time, there's so much public discontent, and primarily can be summarized in people's discontent and complaint and even protest to talk on being not able to afford healthcare and therefore not able to have our healthcare access. And two, the major financial burden that people have to face when they access healthcare. So the 2009 reform is really an embodiment of a change in priority in terms of social value, catalyzed by the SARS outbreak, but also the desire and the need to really address people's dissatisfaction because of unaffordable access to care and also major financial burden. And one important commitment by the government at that time is to increase its government spending by doubling the government spending on health within the 3 years of 2009 to 2012. And the declared goal is affordable and equitable access to basic health care and improved financial risk protection for all by 2020. And we will examine whether China actually achieved that or not. Now, for those of you who work in global health, you will notice that that goal seems very familiar, right? I mean, affordable, equitable access to healthcare and financial risk protection. That's pretty much a form of universal health coverage. And I would say around that time, many countries declared that goal for 2020 as well. But what is unique in China is that China said that it will be affordable and equitable access to basic healthcare, which is implicitly saying that the government has a clear role to assure basic healthcare for everyone, but leaving it a little bit implicit and silent on whatever that is non-basic. Perhaps there will be a role for the market. And this is a continuous dialogue that is still happening today on what is basic and what is not basic. So the commitment that the Chinese government made to increase spending was actually realized. Not only did government spending increase between 2009 and 2012, in fact, if you look at this diagram where we have analyzed the increase in government spending, and from 2009, 2008, the year before the reform, to 2017, which is about 8 years time period, it actually has quadrupled in real dollars. And this is really unusual, and we haven't seen it in many countries, I would say in any country in recent history. And this actually then increased government's allocation to health from its total government spending from about 4% to about 7%, 7.5%, which is signifying that health from the government's perspective is important. And I would say for many countries, whether a country can spend more on health, one, depends on its economic condition. And China was lucky that during that period of time that its economy was booming. But two is also whether the government recognized health as a priority. And I think many of you who work in many low and middle income country setting is how do you get the government to spend more? And some of them can't spend more because they are not able to, but in many other countries also is a priority question as well. So what is that reform consisting of besides spending money? Number one is to expand health insurance coverage for all. Number two is to have the government fund a defined benefit package of public health services. And this is made free for everyone, irrespective of where you live, who you are. And it includes a package of health promotion, immunization, vaccination, the usual thing, but also highlighting screening and management for chronic condition, especially hypertension, diabetes, and also psychosis, because they are concerned with social stability. Screening and management for infectious disease, in particular TB, HIV, AIDS, hepatitis, and also some local diseases. And also screening, a lot of them is screening and prevention, targeting elderly, children, and women. And the third pillar of the reform is strengthening primary health care, recognizing, and I would say that the public health and the primary healthcare part is really motivated by SARS. SARS really shocked the leaders to realize that the primary healthcare system, the most basic public healthcare system, is so broken. And then they also established an essential medicine program, which I won't have time to go into. But interestingly, one part of the reform is called piloting public hospital reform, and I would talk about that. So what has China achieved? By 2011, 96% of China's 1.4 billion people was covered by a social health insurance program. This is a major achievement that I would say, I can say that I don't think anywhere in the world with such scale and magnitude of the population scale was able to do it. And what are some of China's strategies to achieve that? China's strategy at that time is start with shallow coverage, but for everyone. So obviously, even as China's income was increasing at that time, there's not enough money to cover everyone for everything. And I think all countries, maybe except for the rich countries, face this challenge. There's always not enough money. So you have to make a decision. Do you cover everyone with a shallow benefit package, or do you only target certain population and leaving some uncovered? So for example, in contrast, India chose the second route, targeting just a certain population group and leaving some uncovered. The rationale China took was that let's start with shallow coverage because money is limited, but let's take everybody into the system. So over time, as more money is available, everybody get lifted up, everybody get benefits from that. And the second strategy is that it is actually a social insurance program that the government funds a big part of it. The diagram that you see now is the premium, the per person premium for the insurance program. And the blue color is the premium amount that the individual need to contribute, and the orange color is the government subsidy. And you see that government subsidy is a big portion of the total. But China doesn't believe that insurance people should, China doesn't believe that health is a pure welfare program that the government pay for everything. Individuals should have some responsibilities to it. But when I was in the field, it was very interesting that I often said that this really is worth some behavioral economic study. And when the field worker go to enroll people, what they present to the household is, if you pay 30, you then can benefit the additional 120 that the government is putting into the program. So people feel that they would be willing to put in that small share in order to be able to get the benefit that the government is putting into it. So I would say that for many countries who is trying to achieve universal insurance coverage, unfortunately, some level of government subsidies is almost necessary. Well, so then over time, if you look at this diagram from about 2001 to about 2012, you see that total health expenditure made up by out of pocket, the yellow bar, significantly dropped from about 65% to about just 40%. And that is because of the government investment into the system and therefore reducing the out-of-pocket share. So while you would think that, well, now everybody is now insured by, covered by an insurance program, and at the macro level, out-of-pocket spending share has dropped so significantly. Well, that should deal with the problem of unaffordable access to care and also major financial risk burden. The beauty about the Chinese policymakers is that they actually do research and analysis. Actually, in 2021 and then 2023, I mean, what I show you here is up to 2018, they did a midterm evaluation and it shocked them. It shocked them that over time, catastrophic health expenditure, which is an indicator to measure whether people are still facing financial burden. In China, despite a lot more money the government spend, despite insurance coverage, despite insurance actually do pay a bigger share of someone's bill when they go to a hospital. Well, if you look at the data, catastrophic health expenditure measured at 10% threshold, which means that out-of-pocket spending still make up about 10% of a household's income net of food expenses, and is considered catastrophic because it will then be affecting its other spending. Well, if you look at 2007 and 2018, really, it actually has increased. The urban area has dropped. The rural area has even gone up. And if you look at further down the table, the second red circle, Q1 is the lowest income population, Q4, the highest income quartile. Wow, catastrophic health expenditure for the lowest income actually has increased from 21% to 29%. These data really shock the policymakers in China. Medical impoverishment, that is the percentage of people who are pushed below the poverty line because having to pay for out-of-pocket spending. The lowest income people, Q1, pre-reform about 6.6%. It dropped initially a little bit. Post-reform really hasn't changed. And so the question is why? And I think this is an important lesson is because if we look around, many countries in the last 15, 20 years have established social health insurance program. But China's lesson is telling us that establishing health insurance program alone may not achieve what you want to achieve. And what is the reason why people are facing so much financial burden? Well, yes, initially, when people face major financial risk, when people have unaffordable access to care, one reason is lack of insurance coverage. But another reason is because healthcare costs has been growing so fast. And if you look at this this figure, between year 2008 and 2020, in real terms, while GDP is growing at a rate of an annual rate of 6.8%, health expenditure was growing at a 10.8%. Again, internationally, we know that total health expenditure usually grow faster than GDP, but on average, maybe about 10% faster. What the GDP growth rate, the total health expenditure growth in China obviously way exceeded that. So no matter how much money you pump into the insurance system, no matter how much money the government spend more, it's not catching up with health expenditure growth. I almost feel like this is United States. Um, so what was the reason? What is the reason for this health expenditure growth? And that has to delve into where I alluded to earlier, public hospital reform. Let's take a look at public hospitals. Now, in China, public hospitals made up about 90% of the total hospitals. No, I'm sorry, not 90% of the total hospital, but 90% of the hospital beds and also 90% of the hospital admission. There are a lot of small, tiny private hospitals. And so let's take a look at these public hospitals of how they work. Public hospitals only receive government subsidy that makes up about 10% of their total operating revenue. So they have to earn about 90% of its revenue from providing service. China has traditionally been paying its provider by fee-for-service payment system. I'm sure in the audience, you now would say, oh, that's why. Yes, that's why. But there are also two other legacies that was carried from the pre-reform era. China actually regulate prices for the public hospitals, but the fee schedule was set in such a way that it underpays services that involves more labor time. And what are they? Like spending time in consultation and talk to your patients. And that fee schedule overpays high-tech procedures and diagnostic tests. And it also allows markup of 15 to 20% for drug. Well, you don't need to be an economist to know that hospitals then invest a lot in high-tech diagnostic equipments and have high incentive to prescribe a lot of drugs, unnecessary drugs, expensive drugs, and also doing a lot of tests, but not spending time with patients. Any one of you have been to the Chinese healthcare system will know how fast you go into the physician's office, and before you finish talking, well, he's already writing a prescription for you. So even though the majority of the delivery system is public, in terms of behavior, they behave like for-profit organization. And this is exactly the crux of the system that China is struggling to reform. And in 2009, they were not able to find a solution, so then the reform becomes for the public hospital is just a pilot. And physicians who are employed by public hospital is paid by a fixed salary and relatively low salary. And this is again common in many LMIC. But what is different in China is that doctors are also paid a bonus above the fixed salary in order to incentivize them to be very productive. And what is their bonus tied to? Their bonus is tied to the profits made from the drugs and the tests. And so the incentive is all aligned for hospitals and physicians to expand, to grow in volume and to grow in revenue. Again, I hate to say that there's some similarities of what we're observing in the United States. And of course, because of that system, it has created a lot of rooms for under the table payment, kickbacks from drug companies. And for you who follow Chinese news, China launched a major anti-corruption campaign targeting hospitals, especially big hospitals. This has been going on for about 2 years and is continuing. So a typical revenue share in a hospital, the revenue share in a typical general hospital, public hospitals is largely coming from drugs and also lab tests. So then the question is, how do you change that? Now, because hospitals is very incentivized to do a lot and attract patients, and meanwhile primary care is weak. So if you look at the resource allocation, the majority of the money is actually spent in tertiary hospitals. Primary care and even secondary hospitals is only really making up a small part of it. And this is making the system very heavy, very hospital-centric, very expensive, and is a threat to the financial sustainability of the insurance program now. And if you look at utilization, now, if you use utilization as a measure of x-axis, well, I would say that x-axis has been increasing tremendously. If you look at the blue line is hospital admission rate. The several years with a dip is COVID time. And if you look at the last number, 2023, hospital admission rate is now 21 to 22%. Wow, this is really scary. It means that 1 out of 5 person will be admitted to a hospital. The data doesn't tell us what is the reason. And I often joke when I was in China giving a talk, I said, wow, the healthcare reform seems to be getting people sicker. Of course, I was joking. It become very questionable, and our team is actually doing some analysis to look at out of that 21% of hospitalization, how many of them is actually needed? How many of them is actually unnecessary? And then if you look at the share of these hospital admission going to tertiary hospitals is just increasing. Now, this I can tell you that even some of the tertiary hospitals themselves told us that about at least half of the hospital admission are for simple condition that doesn't need to be treated by tertiary hospitals. So there is a very perverse and warped incentive in the system, both on the provider side, because they are paid by fee for service, and every level is competing for patients. But it is also an incentive on the consumer side, which I haven't told you about. When China initially introduced this social health insurance program, it decided that, well, hospital payment must be the major source of financial risk. Therefore, the insurance program should only cover hospital care. And it was a mistake. I would use the word a mistake, which many LMIC countries right now is doing. Only covering hospital care create incentive for patients to go to hospital for simple condition. It also create an incentive for patients to not seek care when their condition is mild, because outpatient is actually not covered. But even if you look at outpatient, there is an increase in utilization. So if we use utilization as a measure of access, I would say major accomplishment in access. But if you look at the utilization pattern, I think we need to be recognizing that there is some efficiency happening. My concern is that, and I think the Chinese government recognize it, a hospital-centric system that is fragmented, that is each level is competing for patients, is not suitable for the need of the population. Like many middle to high income countries' population, the disease profile is predominantly chronic conditions, non-communicable diseases. And with a rapid aging population, this is even more so. So China is facing disease burden from stroke, from heart attack, and from different kind of cancer, and also Alzheimer. Well, a study conducted in 2017 earlier, I still think this is the best study done in China. There are more recent studies that are updated, found that for hypertension, at that time, about if the total number, if the percentage of the population have hypertension is represented on the right-hand side bar, that is 41%, 41 plus 3.23%, so it's about 45% of the population has hypertension. Out of that, 25% of them are not even aware, meaning that it's not just not aware from the patient's perspective, but also not diagnosed. And then another 14% is diagnosed and treated. A small percentage only diagnosed and not treated. Once they're diagnosed, they're usually treated. So the bottleneck is really diagnoses. And as a result, only 3.2% of the only 3.2 percentage point of these 42% of people with hypertension have their blood pressure controlled. My understanding from my colleagues continue to do this kind of work said that the control rate has now increased from about 7% of this study to now about 15 to 20%, but that's still low, which means you have about 80% of the people walking around you, which is like a walking time bomb, I call them. And it is a reflection of the weakness of China's primary healthcare system. So China recognized that it is not sustainable. And so I want to put a very positive note is, as I started in the beginning, what we're observing today is actually a continuous of the reform that China started in 2009. Every few years, China did evaluation and continue to make adjustment and continue to try to deal with the problems that it wasn't able to deal with. The current reform that is ongoing include removing the drug markup, include revising the distorted fee schedule, include changing provider payment from fee-for-service to DRG capitation, and also changing the way public hospital physicians are paid. This is part of the causes of the public hospital system that China is now trying to deal with. And it is progressing gradually. And it's not easy because it is touching the interests of the big hospitals. And big hospitals are powerful politically. The second major initiative that China is moving on is to really build primary care-based integrated delivery system with gatekeeping and focus on promotion. So far, I'm afraid that it is not progressing as well. Most of the integrated delivery system that has been formed in China right now are led by hospitals, which still has an incentive to expand the hospital. In fact, it is using its primary care unit as a unit to recruit patients for them. And I'm afraid there's also some similarities here with the US system. Unfortunately, the primary care level is weak and therefore people do not have trust in them. And over time, people also have equated big hospitals as a measure of quality. And so qualified manpower is a major bottleneck to strengthen primary care. But I would say that the recent expansion and adoption of digital technology is offering, I would say, quite promising future for building up the primary healthcare system. So let me just draw a few lessons for other countries and then I'll pause so that we leave some time for some exchange and question. And again, I'm only giving you a very high level view. And for equity reason and for many countries who are still at a lower and middle income stage, one way to achieve universal insurance coverage, perhaps one can consider is shallow benefit package, but bring everybody into the system for equity reason. Because we have observed in many countries, when you target just one population, it becomes, you create many fragmented risk pool, which become very difficult to bring them back together later on. Lesson number 2 is insurance coverage alone is not going to give you effective care. The delivery system is critical. Lesson number 3 is an insurance system that covers only hospital care is only going to build a very hospital-heavy centric system, and is not going to be suitable for many countries facing disease burden and health needs. China is launching on, I would say, a heroic journey to transform its hospital-centric system to a primary care-based system, but it is challenging. And I hope that we, as researchers, will build more platforms for countries to learn how to do this, because this is not China alone. The idea of integrated delivery primary care base is very much coming from England, which has a strong primary care system, but I challenge you that in many countries that in lower or low middle income countries, the primary care system on its own is actually weak to start with. How do you transform them? How you eventually become the focus that can then integrate upward? I know there are countries that are doing it better, including, for example, Brazil. So I think we really should be learning more from each other, even among the advanced economy that is trying to move towards more of a population-based approach, like what is happening in England and even in Singapore. I'm going to pause here, but I would like to say that having worked in China for 25 years or more has lots of moments of frustration, but I think I feel very privileged to be involved in this process, because I think a lot of our analysis and research has actually contributed to the reform decision. It's a long process, but if we are patient enough, it actually does happen. Thank you very much.
Well, thank you so much. What a fascinating and fantastic talk. And I know China is a big place, and you said you would be high level, but I think you offered us lots of really nuanced insights. We do have some questions, so I'm going to turn to those. I'm going to combine a few. So we have a couple of questions about more detail about primary care. Can you tell us a little bit more about the primary healthcare system as it exists in China? Are there community health workers? And how do referrals work? For example, do you have to refer to tertiary, or how does that?
Great, great. So first of all, in the rural area, the primary healthcare system consists of, at the bottom level, what we call village doctors, in a village clinic, and a village clinic is typically just staffed by one village doctor. But if we use the global language, they're really community health workers. Even though they're called doctors. And then at this next level, there are what we call township health centers. And I would say if we use the global language, they would be like community health centers. And in the urban area, there are community health centers. And in these community health centers, I would say that some of them do have a medical degree, but in the rural area, the majority of them do not. But they have a few years of what we call health school education. And so what China is doing right now is trying to staff them more with doctors with GP training and family medicine degree, but has been not too successful. And I think you can all understand why, because everyone who has gone through medical school training get socialized and don't want to return to the village, don't want to go to a community health centers. And I would say that within the medical profession, I keep telling them that you need to change this. They still feel that the smart students become surgeons. It's only the incompetent ones go to the community health centers. And this is really a big barrier. So China is working hard to increase compensation, to motivate people to go to community health centers level, but I don't think that is enough. Then the next question is, unfortunately, there's no gatekeeping. Referral is not required, and therefore patients just go directly to the hospitals. So China's economic development means that it has built many, many, many roads. The roads also make it very convenient to people to just go directly to a tertiary hospitals. And that is actually a major barrier to build the primary care base integrated delivery system. So great question.
Yeah, thank you. I was curious about the cost of increasing technologies, and this is not unique to China by any means. So the cost of technology, advanced diagnostics, and the balance as to whether that actually improves health outcomes, changes mortality. And I'm wondering if your own research, you're able to look at or trying to look at how this, in addition to access, how have the changes improving the lives or life expectancy or quality of life or those factors?
So, if you look at life expectancy in China, it has been increasing. But I am a bit skeptical that this increase is due to technology. I think it's more largely due to an improvement more in nutrition, social, economic condition, because a few years ago, we actually collected data the from a sample of about 20 top level hospitals and then measure their quality for selected number of health condition. And quality is measured by whether you do the right thing at the right time, right? You're familiar. And it wasn't done very well. So interestingly, also in those measures, anything that is related to doing a test within a certain period of time, those are done very well. But anything that is not related to tests is not done very well. So I would say that given that analysis that we did, I'm a bit skeptical that technology alone has explained that improvement in health outcome. And I think maybe a little bit better rebalancing may be useful. Yeah.
Thanks. I'm going to squeeze in one more question, and we have a lot of questions from the audience, so sorry if we didn't get to them all. You mentioned about how the SARS outbreak was part of an incentive around change and reform, but I'm wondering about how outbreaks of infectious diseases maybe have impacted trust or how strong trust is in the health system, in public health. I mean, you mentioned people going from rural areas straight to the hospital. Maybe there's more trust in the hospital system, but could you talk a little bit about trust as you see it and how that impacts any of this?
So yes, I didn't emphasize it, but on my slide, you will see that I think there's a general problem that I think patients do not trust the primary healthcare system. But I would say that the trust between patient and physician is also a little bit questionable. They look at tertiary hospitals and use sort of more their hardware, like they have the most expensive drug, they have the most expensive technology as a signal for quality. But the trust between physician and patient in China is actually not at the best time. Now, for primary care level, the trust is about their competency. At the highest level is, I think patients actually did recognize that at big hospitals, physicians overprescribe, and therefore they're given things that might not be necessary and costing a lot of money. So there's that question as well.
This has been absolutely fascinating. I'm so grateful for your time. We have just 1 minute left, so I wanted to offer you the opportunity to share anything that you wanted to share and you didn't get to, or a final closing reflection before we leave the session today.
I think what China has done in the last 10 or 15 years are reform actions that they have learned from analysis, theory, or what other country have done, right? And I think what they are now confronting are a number of challenges and issues that I think many countries also confront, high, middle, low income, and still haven't gotten an answer. So I think it would be wonderful to form community of research and learning to really learn more and draw lessons from each other. China has spent many years encouraging pilot experiments, and I think that's such a great place to work in when you can do um, pilot tests. because it would be a little bit dangerous to try to roll out a policy without learning about the feasibility. And for all of that, I hope we continue to have these conversations because I think we're all confronting similar problems.
Yeah, very much so. And we have so much engagement from our audience. I think we definitely need to have you come back and share again in more detail. So thank you very much to you, Professor Yip.
No, thank you.
Thanks to all of our audience for joining us. We will be posting the recording on our website in the coming days for anyone who missed it, or if you want to share it forward. So thank you all very much. Have a wonderful rest of your day.
Thank you. Thank you very much for doing this.
Thank you so much.